Today we're gonna finally kind of cover some of the. I know we've touched on some of the other types of sleep studies that you can see and do within overnights and within the field of sleep. We've touched on them, especially when we talked about like reviewing an order form and making sure that the study that we're doing is appropriate. We're going to get more in depth on the different types of studies that we do within a sleep lab. MSLT stands for multiple sleep latency test, and it's actually a daytime test that we do with the patient that tests their propensity or how quickly or likely they are a person is to fall asleep in an otherwise sleep inducing environment. And how we do that, and it's kind of like, how medical trials or other types of like scientific trials, you have to keep repeating it a few times to see the results. Same kind of theory behind MSLT, where we have the patient take 4 to 5 naps. Mostly, we'll say 5 naps, and then I'll explain why we can cut off the last nap in a little bit. But we'll say 5 naps during the day. They have to come in and do an overnight sleep study preceding the daytime test. That's so that we have a really good picture of how their night went, make sure that they slept enough, that there isn't an identifiable reason for why they're so tired, why we're testing to see how quickly they can fall asleep. And what we're also looking for is what stages of sleep they go into. So specifically, are they going into REM? If we're only running about a 20-minute nap, should you see REM on an average or normal person? No, because REM onset or typical REM onset is 90 to 120 minutes. If a patient goes into REM during any of those naps, then that could be very kind of indicative that they could possibly have an issue, specifically narcolepsy. So narcolepsy is a disorder that is really, number one, it's very poorly portrayed in the media. You've probably seen like movies or TV shows where they've had a patient or person that's narcoleptic, and they've just shown a person just falling asleep kind of very inopportune places and times and that type of thing. And it's it can present itself that way, but that's not the norm. When you think about narcolepsy, what I want you to think about is it's really a disorder of kind of blurred lines between wake and sleep. Most humans, wake and sleep are two very distinct states. When you're awake, you're awake. When you're asleep, it takes a little bit to fall asleep, but then you're asleep. Unlike a dog, like if you ever watch a dog, they can fall asleep so quickly and then they can wake up like nothing. So, it's similar to that. With a narcoleptic, kind of they don't have these two very distinct states, and you start to have kind of blurred lines between wake and sleep. And what that can translate to is components of sleep can kind of continue to occur while you're awake, and specifically REM sleep. So it's specifically blurred lines between REM sleep and wake. And so if you think about the state of REM, it's a disorder, or it's not a disorder, it's a state where we have muscle atonia, so we don't act out our dreams. We typically have these very vivid, kind of hallucination type like dreams, these very movie like sequences. Um, and that can occur. What happens with a narcoleptic is the components of REM can continue to last once you're awake. So, like for instance, as you're waking up, mentally you're awake, but you could still be seeing like hallucinations or dream-like things happening. And it doesn't even have to be visual. It can be auditory. It can be tactile, like feeling something like somebody's touching you or something. And the sleep paralysis, which is where when you have the muscle atonia of REM, um, you can wake up and while you're mentally awake, still feel like you're paralyzed and not really be able to move anything for a few seconds to a few minutes, and it ends spontaneously. And you typically see this happen in the sleep wake transitions, either falling asleep or as you're waking up. It can happen to anybody. It can happen those kind of they're called hallucinations or sleep hallucinations or sleep paralysis, those two things, especially if you're really tired. Has anybody ever had anything like that happen? I think I knew that. Didn't we do the test on you last year? It's incredibly scary if it does, and oftentimes they occur together. Um, if you're really sleep deprived, being sleep deprived can bring out a lot of these abnormal things. So I have had sleep paralysis once in my life, and it was because working overnight. So something to look forward to. And it was accompanied by the hallucination as well. Like it was like I was having a dream that somebody had broken into my house, and I woke up and I couldn't move, and I could hear him and like see him taunting me, and I couldn't even move. And then I finally woke up fully. Um, it's incredibly scary because you don't really know what's happening, or, like what's going on. And that's why a lot of these patients kind of delay getting tested as well, or even talk to their doctor about it, because in terms of the hallucinations, it could be oftentimes it could be in the like a sensed presence, like you feel somebody in the room. And so you think you're losing your mind, like nobody's going to believe me, they're thinking I'm like seeing ghosts or something. Or like the paralysis, it could be like, what, do I have a brain tumor? And so you get some people, and I think we're all guilty of it at some point or another, where if you have kind of symptoms of something that could be really serious, it's easier to just kind of bury your head in the sand and ignore it versus going to a doctor about it. So a lot of these patients don't really, they can kind of delay treatment. um, in order to diagnose narcolepsy, we're going to do the MSLT on them, and we're going to look to see what stages of sleep they go into. And so if they went into REM on 2 or more of the naps, then we don't have to do a 5th nap. They already diagnostically meet the criteria. That's when we can send them home. Most often, though, we're doing 5 naps. So just think 5 naps for this test. So how they're run, the naps are 20 minutes long. We space them out at 2-hour intervals, and you're really looking at how fast the patient can fall asleep. So it's a measure of their sleepiness level. We've talked a lot about subjective measures of sleepiness, which is the patient's questionnaires, the Epworth, all of that. This is an objective measure of their sleepiness. So if they're coming and saying they're super duper tired, well, this will be that kind of that test that we can do that can really put a number or a value to how tired they're saying they are. After we wake the patient up from the overnight sleep test, we start the naps about 2 hours after they wake up. So if we wake them up at 6 a.m., the first nap will be at 8 a.m., 10 a.m., 12, 2, and 4. So they're at the sleep lab for close to 24 hours. It's a long testing period for them that they have to keep everything on because we're measuring everything. So the MSLT looks to see how fast the patient falls asleep, and if they enter REM, how many times they do across all those series of naps. And it ultimately tells us if the patient does have excessive daytime sleepiness. And it is the definitive test for narcolepsy if we see REM. And it's the only test now kind of used in conjunction with the patient's history that we can definitively say a patient has narcolepsy. They used to do cerebral spinal fluid testing for narcolepsy, and there was only one place left, Stanford, I think in Connecticut, was doing it, and they don't even do it anymore. So this is the only way a person can get diagnosed for narcolepsy. And it really looks at if a person is coming to the lab and says that they're really tired, it differentiates. Are they really tired because of, like, say they had obstructive sleep apnea? Well, we know why they're tired then. That's why we're doing the overnight study beforehand. And if it shows that they're positive for like OSA or some other severe sleep disorder or something, we wouldn't even do the nap test because there's no point. We know what the issue is that's causing them to be tired. But if we don't really have a great cause as to why they're tired, we then want to look at, okay, are they really tired pathologically? Is it truly coming through that they're tired, where we can measure it, or is it more of like they're just subjectively kind of amplifying their symptoms? That's how we're able to get this value of how they're doing. And then what's causing their sleepiness? Like, is it narcolepsy, or is it some other cause that could be causing them to be really tired. So more than two sleep onset REMs is considered positive. The new standards, they just updated this about 2 years ago, is that the patient might only have one sleep onset REM in the NAP study, but if they went and had a sleep onset REM on the overnight sleep study as well, that counts towards the two sleep onset REMs. So that's one of the reasons why we do an overnight sleep study beforehand. How quickly did they get into REM on the overnight as well? If they are really tired, meaning the average that they fall asleep is quite quickly over the course of the 5 naps, but they didn't get into REM, that means they don't have narcolepsy, or in all likelihood don't, most likely don't. But they are pathologically sleepy. And so the diagnosis given would be idiopathic hypersomnia. Idiopathic meaning we don't know why. And think of insomnia is the inability to sleep. Hypersomnia is overly tired, too much sleep. Okay. Big name, I get it. But if you kind of just break it apart, makes it a little bit easier to understand. So basically, with idiopathic hypersomnia, it means the patient falls asleep quickly. The average of how quickly they fall asleep over the course of the 5 naps is fairly quick, but they don't get into REM. So it shows, yeah, these people are really tired, but we don't know, it's not narcolepsy, and we don't exactly know why yet. It's a physiological measurement of sleepiness. So think of, again, always remember, like, sleep is a basic need. Just like hunger is reflects the basic human need to eat, thirst reflects the basic human need to drink. Being sleepy reflects a basic human need of needing to sleep. And so this physiologically measures it. We're not just going by what the patient's saying. We're not just going by the questionnaires or, how they're reporting their symptoms to be. This is a definitive test to be able to say, yes, this is how tired this person is. And it either supports their claims or it can refute their claims. Um, so essentially, how the test is run is we remove things that could potentially keep the person awake. So anything that could be like a stimulator, we put them in a very sleep inducing environment. It's a cool, dark room, no TVs, nothing to keep them awake. And repeatedly, 5 times throughout the day, tell them, okay, don't fight the urge to sleep, meaning try to fall asleep. And so, how we measure their sleepiness is we measure it by how quickly they fall asleep over the course of the 5 naps. And we're really looking at the average that they fall asleep. It's one thing, like any normal person, we might fall asleep once or twice over the course, but 5 times every 2 hours. Could you imagine being told to lay down? I mean, right now I'm tired, so that seems like heaven. But by the third, fourth nap, you're not going to be falling asleep each time, or if you do, it's like very at the tail end of the nap, versus like somebody that is truly physiologically sleepy. They're going to fall asleep pretty quickly, repeatedly, for the most part, over the course of the 4 or 5 naps. I just said all that. So the MSLT is performed as part of the evaluation if a person's presenting with saying they're very tired and presenting symptoms that they are, but we don't have an exact cause of it, or they're showing symptoms that it could potentially point towards narcolepsy. Meaning, like, do you guys remember the questionnaires, going through that patient questionnaire? There are questions that specifically ask about symptoms that kind of point towards narcolepsy. Like, do you have dreamlike sequences upon falling asleep or waking up? Do you ever feel like you can't move when you first wake up? So it's asking about the symptoms of narcolepsy, um, in a kind of more roundabout way without showing it. So if the patients are indicating that they have had those symptoms, then in all likelihood an MSLT would be ordered to see, okay, can we see if they truly do have narcolepsy, or are they kind of misinterpreting what's happening, or maybe they do truly have those symptoms, but it might not be related to narcolepsy. So because this measures the sleepiness, physiological sleepiness, there's a lot of behavioral guidelines that we need the patient to follow, because there's a lot of things that can impact your ability to fall asleep. And we want to remove all of those and just really take a look at like naturally how quickly you would fall asleep over the course of the day if you're given the opportunity repeatedly to do it. So if a patient is a smoker, they can't smoke at least a half hour before the start time of their naps. And so at the beginning of the day, after you wake them up from the overnight, you would give them like, okay, an outline of this is what time we're running your nap. So this make sure they know these are you can't do this, you can't do this, like at least a half hour prior, because smoking is a stimulant. Any vigorous activity has to be suspended. Like they can do light activity, walking around, whatever. And you would notice too, most patients don't do vigorous activity because they're all wired up. Like it's not like we're taking the wires off and then reapplying them every 2 hours. It's just left on. So it's not like they really can do a lot of vigorous activity. Get them ready for bed. We're going to do the biocals, have them do a questionnaire about how they feel, have the patient lie down. And then what we're going to tell them is lie quietly, keep your eyes closed, don't fight the urge to sleep. And then you start the trial. The reason why the verbiage of is don't fight the urge to sleep instead of try to fall asleep is it's like it's psychological. If I were to tell you to do something, it almost puts that pressure on, like, well, what happens if I don't? Am I going to fail this test? Maybe it's not going to show what I needed to show. I had to take a lot of time out of work and childcare and everything be able to spend this much time in the lab. Like, what if this doesn't show what I needed to show? What if I don't get answers? Like, have you've done the spiral, right? You've done it. Our patients easily can do that spiral as well. So it's those little nuances of our speech and how we explain things and how we say things that can make a difference. And that's why we're trying to remove that psychological stress of like, well, what if I don't fall asleep? She's telling me to fall asleep, but what if I don't? And and you've done that before, like where if health wise you have things that are bothering you, you have a lot of things going on, you want answers. And so the fear that a lot of our patients have is, what if this doesn't give me the answers I need? And we want to try to remove that fear. Like it's going to give us info, it's going to point, if it doesn't give you the answer you want, it's at least the very least going to point you in the direction of what step to take next. So that's why psychologically we try not to say go ahead and try to fall asleep. It's don't fight the urge to sleep. So the things that we look at when we're running this MSLT is we want to look at when they fall asleep, how quickly they fall asleep, their sleep latency. It's just same as for when we're looking at an overnight. The definition of it is from lights out to their first epoch of sleep. And we look at if they have a sleep onset REM, which is if they hit REM within 15 minutes after sleep onset, that's considered sleep onset REM. How to end the nap. So naps, I tend to tell the patient they are like around 20 minutes, heavy on the ish again, because we really base when to end the naps on what the patient is doing. So if the patient is able to fall asleep from sleep onset, we give them those 15 minutes to fall to sleep. Even if they wake up remember the definition of REM onset is from sleep onset to the first epoch of REM, even if they wake up in there. So you guys remember when we were going through the PSG reports that a lot of them have like what the REM latency is and what the REM latency is less the wake time. And I said, that's not truly the REM latency by definition. It's just a little extra info that the report gives you, but it's not truly the REM latency by definition. Same thing with the results of this. So you try to give the patient time to fall asleep. You give them 20 minutes to fall asleep. If they fall asleep within that 20 minutes from sleep onset, you give them 15 minutes to sleep. So naps can be as short as 15 minutes, assuming that they fall asleep right as we start the nap, or they can be as long as 35 minutes. Say they fell asleep right at that last minute of the 20 minutes that we give them to fall asleep. Then we'd let them sleep for 15 minutes beyond that, and the nap would run for about 35 minutes. Make sense? Want me to say it again? Okay. So we give the patient, the naps are spaced 2 hours apart. And so say they woke up at 6, first nap would be at 8. We give them, if say lights out for the first nap is at 8 o'clock, we give them until 8:20 to fall asleep. If they fall asleep within that time, whatever time they fell asleep, whatever time you say sleep onset is, they're given 15 minutes to sleep. So it changes the end of the nap. Okay. If they fall asleep right at sleep onset or right at lights out, which would be 8 o'clock, then we're ending their 15 minutes. We wake them up at 8:15. If they fell asleep right at that last minute at 8:20, then they're given till 8:35 because sleep onset was at 8:20. So the nap itself will run, the trial will run for 35 minutes. Whatever point within that, and where they're given 20 minutes to fall asleep. If they fall asleep, wherever they fall asleep, they're given 15 minutes to sleep. So I get the numbers because 15, 20, sometimes it gets confusing. It's one of those, just kind of like start committing it to memory, do your little flashcards or whatever you need to do. The data that we look at and how we evaluate the sleep latency or the MSLT is we really want to look at what the average or mean sleep latency is, what the median or which one falls in the middle, the mode or if there was one that occurred the most, and what the REM latency would be. So sleep latency, again, is the lights out to the first epoch of sleep. And you're essentially going to take the average across all of the naps. So how quickly they fell asleep in nap 1, 2, 3, 4, 5, divided by the number of naps that was run. So we take the average of how quickly they fall asleep. If the patient did not fall asleep, then their sleep latency is recorded as 20. Okay, just for math purposes, because you're still going to include that in the average. If we didn't include it, it looked like they had a lot smaller of a sleep latency than they actually did. It's kind of discounting the first nap. So if they didn't fall asleep, the sleep latency is recorded as 20, and you would just take the average of all of those numbers. So the average sleep latency would be 9.1. The lower the average, the sleepier they are. So if they have a mean sleep latency of between 0 and 5 minutes, they have severe sleepiness. 6 to 10 is considered troublesome. Remember, the normal sleep latency is 10 to 20 minutes, so we can work with that. So at mean sleep latency between 11 and 15 is manageable. 16 to 20 is excellent, because anybody, if you're given the chance to sleep, eventually you will sleep. It might not be happening on every single nap, but eventually you might. Median is when you line them all up numerically, whichever number falls in the middle. Mode is if there is one, if there's a number that occurs more frequently than the others. So if there's one that repeated itself. I don't know why they need this. REM latency is the average amount of time that they got into REM. Now, the difference between mean sleep latency and mean REM latency is, remember, mean sleep latency, we're taking the average across all the naps. So if they didn't fall asleep, you're recording it as 20. With REM latency, the average REM latency, you're only taking if they got into REM. What's the average? How long did it take them to get into REM on the average that they did get into REM? Make sense? I'm going to say it again. Mean sleep latency takes the average sleep latency across all 5 naps. So even if they didn't fall asleep, you're recording that as sleep latency of 20, and you're including it in the mathematical calculation for your average. Mean REM latency is only the average REM latency of the naps that they actually got into REM. So if they didn't get into REM at all across any of the nap, there's no mean REM latency. Does that make sense? Okay. Narcolepsy, they're positive for the diagnosis of narcolepsy if sleep onset REM occurred in 2 or more naps. You guys want to do this together, or you want to do it on your own? It's basic math. Do your averages. You guys do it. So what'd you get for the mean sleep latency? 12. So it's just the average of all these? What does a mean sleep latency mean? What does a mean sleep latency of 12 mean? What's the level of sleepiness? Manageable. What is the mode? Which one occurred the most, if there is one? 7. What's the median? If you line them up all numerically, which one falls in the middle? 8. And now calculate your mean REM. Eight. Yeah, because you're only taking the average of when they actually reached REM. So 13 plus 3 plus 8 divided by 3. So if you have 3 REM latencies, that means they are positive for narcolepsy. So there's two things that we can evaluate based off of the results of the MSLT. Their level of sleepiness based on their mean sleep latency and whether or not they're positive or negative for narcolepsy if there was sleep onset REMs or not. So because the MSLT and a person's ability to fall asleep is so subjectively impacted by caffeine, medications, a person's age, how much they actually slept before the daytime nap. So if you went into the nap study heavily sleep deprived, like pretty much pulling an all-nighter, you're pretty much going to be able to fall asleep each time. Because of that, we need to do the sleep study the night prior to validate that the patient got enough sleep and also what's happening during their sleep. And a lot of labs do choose to urine screen the patient, have them go for a drug test right after the conclusion of testing. So some of them are like most labs are not don't have that ability to do it like in sight. So as soon as their last nap, they're instructed to go to another like a drug testing facility to have their urine screened to make sure that they did abide by the rules in terms of caffeine, medications, everything like that. Um, Kind of get a little off topic, not off topic, but so with the medications, because like I know we haven't gotten there in pharmacology yet, but like specifically antidepressants significantly delay REM. Even a person was positive for narcolepsy and were on antidepressants, they probably wouldn't pop positive on the MSLT because the medication is just blocking them from getting into REM as quickly as their body normally would. So a lot of patients are told to withhold and wean off of certain medications prior to coming for the MSLT, specifically antidepressants. And they usually have to be off of it for at least 2 to 3 weeks to make sure it's completely out of their system. It's so important. That's where medication reconciliation is so important because I've had patients come in and it's on the order form, like the physician wrote, patient must withhold X medication for X amount of time. And you ask them like, when's the last time you took this medication? And if it wasn't within the time frame, we have to cancel the study and send them home. If I did not verify that medication and the patient took it, and we found out later on the patient took medication outside of what the physician's instructions were, it would invalidate all the results. So this, an overnight sleep test is about $2,000. I don't know how much they charge for the MSLT to be perfectly honest, but that is a cost that the sleep lab would have to then eat to repeat the test because of my mistake. You get the brevity of that, correct? Okay. So that's why you must follow the rules, verify with the patient, all of that. If the patient did not sleep at least 6 hours on the overnight prior, we would send them home. There's a lot of things that can invalidate the MSLT that would cause us to not go through with it. So if their total sleep time was less than 6 hours, we're not going to do the MSLT on them. We know why they're tired and it's going to sway the results of the MSLT. You would cancel it, send them home. The maintenance of wakefulness test, or the MWT, is similar and opposite to the MSLT. So it's a daytime test, and whereas the MSLT tests a person's ability to fall asleep, the MWT tests a person's ability to remain awake in an otherwise very sleep-inducing environment. The thought behind the MWT is if a person's ability to stay awake or inability to stay awake poses a threat to themselves or to the general public, think pilots, bus drivers, things like that, we want to test their ability to stay awake in an otherwise very sleep inducing environment. So it's similar in that they're performed at 2-hour intervals. What we do is we'll run the trial for 40 minutes. Um, and basically the patient is placed in a recliner, but reclined. So they're not fully laying down. They are semi upright. And the room is dark, cool, quiet. And we just tell them, fight the urge to sleep. Try not to fall asleep. They are not allowed to engage in any behaviors that would keep them awake, like slapping themselves, kind of really toe tapping, fidgeting, moving around. They have to just sit there and mentally try to stay awake. If they fall asleep at any point during the trial, yeah, you wake them up. That we're just looking at how long they can stay awake for in an otherwise sleep-inducing environment. I don't care what stage of sleep they can get into. It's just, can they stay awake? If not, once they fall asleep, we end it. If they are able to stay awake, the trial is ended after 40 minutes. It's an objective measure of the patient's ability to stay awake in an otherwise sleep-inducing environment. The problem with the MWT is it hasn't been as validated as the MSLT, whereas the MSLT, we have very set standards, like this is what this means, this is what that means, and MSL mean sleep latency of this means this, and this means this. The MWT, we don't really have that. It's just more if the patient was able to stay awake across all 4 trials, we know the patient's good. That's the best data we can get. Um, but if they can't stay awake and their mean sleep latency is less than 8, it's abnormal. And values between 8 and 40 are kind of uncertain. It's more of like a case by case scenario of what the patient is getting tested for. So it's used in association with the patient's history. It can be like a measure of a patient's response to treatment. So maybe they did test positive for narcolepsy, and we would just want to see how their treatment has been going. So we can do this test instead as a kind of a follow-up to see if their treatment plan is going well for them, if they need to alter their medications, if they're still really having trouble staying awake. Sometimes it's done if a person has lost their driver's license because they fell asleep behind the wheel. The state might require this test to be done to see if they can get their license back. Or certain professions, like having the diagnosis of obstructive sleep apnea can be limiting for certain professions. Like I know somebody that was in the Army, and he did not want to get diagnosed with OSA officially because it could make him lose his job and everything that he was doing. Um, so some people, truck drivers, whatever, if the company's mandating it, they might have to do this to make sure that they're not only that they're compliant with treatment, but treatment's working for them before they're allowed to get back on the road or something like that. We have to continually visually monitor the patient. So we've got them on the camera, and we are constantly monitoring them. This is the only test like that. Like normally we would mainly watch our signals to see like what's going on, and the camera's there to kind of pick up an idea of what the patient's doing or things like that. But this one, we are visually monitoring them to make sure that they are not engaging in any behaviors to keep themselves awake, like pinching, tapping, humming, anything. If they engage in anything like that, the trial's ended and it's considered invalid. So the patient basically sits in a semi-reclining position. If there's no recliner in the sleep lab, you do have them get into bed, and you can kind of prop them up with some pillows and just look ahead of just stare straight ahead, whatever you got to do. Nothing to keep yourself awake, no walking around, anything like that. And it's important that the patient knows this, because if they were to engage in any of these behaviors and we're like, okay, the test is invalid, you just did that. And they're like, well, you didn't tell me. I didn't know I couldn't do that. So we need to make sure that we are best explaining these tests to the patient so that they know what's expected of them. So here's kind of a breakdown of the comparison of the two. It tested MSLT tests the patient's ability to fall asleep. MWT tests the patient to wake up. Um, the montage is the same. So basically with the MSLT, we do a full sleep study on the patient. They've got all the wires on. We don't need leg leads. We don't need the snore or any of the respiratory sensors for the MSLT because we're literally only looking at whether or not they fall asleep. So we can take those wires off in the morning and we're just leaving everything needed in order to sleep stage. All your head wires, the EEG, the eyes, the chin, and then your EKG, because we always need to monitor EKG for patient safety. So prior to, either of these tests, the patient has to be evaluated by the physician, especially the MSLT. The patients might be told to withhold certain medications, and usually this test is scheduled about 2 weeks after they fully come off the medication. So if they have to wean, it could be a lengthy process before they finally come in for the test. And for some patients that cannot come off of their medications fully, like certain antidepressants or mood stabilizers, basically the physician will work very closely with them to get them to the lowest dose that they can tolerate. I will say I have had patients that have gone through the weaning process, and it could take months of like weaning first off one medication, then the other, and then they finally come in for the MSLT and they go, I feel fine. Now that I'm off all my medications, I'm not having any of the issues I was saying before, which is interesting. Um, Generally, the patient keeps a sleep diary or a sleep log for the 2 weeks leading up to their test, because you need to look at what the average of their sleep has been in the 2 weeks. Just like how we do the overnight sleep study to see are they getting at least 6 hours of sleep prior to the MSLT. If they are, even if they get at least 6 hours on the overnight, on the one night preceding, but they have a cumulative, very like big sleep debt accumulated over the 2 weeks, like they've been depriving themselves of sleep, then they're going to be really tired regardless of how much sleep they got on the overnight, so they're going to sway the results that way. So that's why we need to do sleep diaries for the 2 weeks leading, and you have to look at their average total sleep time. It has to be at least 6 hours for the 2 weeks each night for the 2 weeks preceding the test. Um, so things that might cause us to cancel the test is if their total sleep time is less than 6 hours, or if their arousal index is more than 20. If they have an arousal index greater than 20, it means that, listen, this patient is waking up to a significant enough degree that we need to figure out why they're waking up so much. That's most likely the reason that's contributing to them being tired. Make sense? We're not looking at the RDI. They could technically have obstructive sleep apnea and have an RDI of, whatever. We're mainly focusing on the arousal index. How many times are they waking up on the overnight prior? So you're looking at two values that could invalidate and cause you to send the patient home based on the previous night study: their total sleep time and their arousal index. If the patient has OSA, like a concurrent OSA, in addition to like their sleepiness issues that they're coming in the MSLT for the MSLT to get tested for, they're going to do everything with their PAP on. So that's where that option for a baseline with PAP is there. Because that's more of a complicated case. Like if the patient has obstructive sleep apnea, that's kind of gonna, OSA is one of those things that really kind of takes precedence and makes itself the most well known when we look at the results of a sleep study. And then it's not until after we take care of the OSA and the patient's treated that if they have any other sleep disorders, it can become a little more obvious. So same thing with like narcolepsy. So once the patient's OSA is treated and they're still coming forward with complaints of really being heavily tired, maybe some other like the abnormal behaviors, and it's like, man, so maybe it wasn't because of their sleep apnea. Now let's explore further. So if the patient does have sleep apnea and they're being treated for it, it's like running a baseline but with their CPAP on. So you're still going to use the same criteria, like make sure that their total sleep time is at least 6 hours and their arousal index is at least 20. And same thing, you're going to run the naps with their PAP on, and you just leave it at their prescribed setting. It's not like we're titrating or anything like that. The MWT, it's really at the physician's and the lab's discretion whether or not the patient's brought in the night prior or whether or not they're just brought in for the day. Um, it really depends on, I think, the exact circumstances of why the patient's coming in and what the physician's preferences are. Certain instances, they might have the patient withdraw on certain medications, or they might make sure the patient is continuing their medications and has been compliant with their medication regime, especially if they're there for the reason of testing, is this medication working for them to help them stay awake, right? So MWT, we need to make sure that we are giving them the instructions to make sure that they know how they need to behave during the test. They should be out of bed. We have to visually monitor them. We don't need to like stay with them the entire time, but you need to routinely and frequently check in on them. Make sure that they're not dozing off, which honestly happens a lot more than you realize. Like they'll go down the TV lounge or something and start nodding off in front of the TV. Make sure they're not consuming caffeine, things like that. Um, Questions on the MSLT MWT? Do you guys want to take a little break before I keep going? Okay, let's take a break. I do want to say, so you guys know on Blackboard how I have that like a little 5-10 minute video on like OSA, just kind of give you a quick background on the disease, give you a better understanding of it. One of the senior assignments was to do that for narcolepsy, and I think I'll be able to post it today to kind of give a little more background on what narcolepsy is to better understand what we're looking for and stuff. It's like short little thing, but let's keep going. REM behavior disorder is a disorder where you act out your dreams. So that what's going on in these patients is that muscle atonia or muscle paralysis that should occur and typically occurs during REM does not for these patients. And so it ultimately results in them, they could twitch, jerk, kick, punch. It usually is limited to the bed. It's not like sleepwalking where they're up and around and ambulating. It's usually them just kind of like flailing around in bed. And they typically will wake up afterwards, and kind of pretty much can tell you exactly what they were doing, whether they were like fighting ninjas or whatever. The thing that most often happens with these patients that brings them into the sleep lab is some kind of injury, usually to themselves or their bed partner, um, because it's just you have no control over what you're doing. So either whether there's a nightstand nearby or whatever. The most, did I tell you guys the most severe case I ever had of this? Guy came walking into the sleep lab and he had a giant boot on his foot. And we normally kind of have to really take a look at and evaluate each patient individually if they're coming in with an acute condition, because you have to look at, is this going to negatively impact their sleep, or we're not going to get a good idea of what their sleep is normally. So I was talking to him about what happened, and basically, his wife had kicked him out of bed because he punched her a few too many times, and he was sleeping on the couch. And the couch that they had like the wooden ends, not the padded, and he put his foot through it. So that's what brought him to the sleep lab. Not that he punched his wife and she got to a point where she would refuse to sleep with him, but because he hurt his foot and had to come in. And that's usually what happens is these patients injure themselves, which is why it is important that we get them treated. So the REM behavior disorder study would include the full kind of workup, the same diagnostic leads that we put on for a baseline study, but with a few additional ones to better be able to see what might be happening if they were to act out their dreams. So you might put leads on their arms to get arm movements, EMG leads, just like we do on the legs, but you do it on the arms. Make sure that the video is in record mode, especially during REM. And they typically will also try to record the audio because you might have vocalization, shouting, things like that. Make sure you're documenting super well. So sometimes they have you record everything, the entire study, or they might just have you hit record as soon as you start seeing them go into REM. Depends on the lab. Um, Also, depending on the lab, they might have you add additional EEG leads, kind of like a seizure montage. So a seizure montage would be adding extra leads to be able to better see if the patient is having seizures, where in the brain it's happening. REM behavior disorder can sometimes present itself where kind of the differential diagnosis, which is where you're looking at like, well, the symptoms differential diagnosis, meaning the symptoms you're coming here with, it could be any of a few things. We don't want to rule anything out. So let's kind of widen the umbrella of what we're looking for. And same thing with REM behavior disorder. It could actually be a nocturnal seizure disorder. It looks like they might be acting out their dreams, but maybe they're actually having seizures during the night, causing these crazy movements that's happening. So depending on either the diagnostic picture or just the lab itself, it might just be their policy that if we're doing a REM behavior disorder study, in addition to whatever extra leads the physician or the lab wants, you're also going to be adding on these additional EEG leads and looking for if it might be actually a seizure or origin versus REM behavior disorder. Moving for nocturnal seizures, again, it's kind of the misfiring. We think we talk about seizures next week, actually. Yeah, we do. But it presents itself differently in the brain waves. And so to better visualize and see seizures, you would do additional, pretty much the full 21 lead measurement, like all electrodes on the scalp. So we can see if the patient's having a seizure, where it's originating from, what part of the brain it's impacting. Also making sure that you're recording audio and visual, especially if it causes them to have any type of abnormal behaviors or things like that, what's happening with the patient, and good documentation throughout. Seizure study, we still do everything. So basically when I say like these extra studies, like it's not, we're not taking anything away. We're still doing the full array of electrodes that we would for a baseline. We're just adding more to it. So you're still putting on the leg leads, you're still putting on the respiratory monitoring, you're doing it all, but you're adding more to it. Home sleep studies. Home sleep studies, sometimes you'll see them referred to as ambulatory sleep study, portable monitoring, out of center sleep testing, home sleep apnea test, all used interchangeably. Basically what it means is we're doing some type of monitoring or recording, not in the lab, meaning it's in the patient's own environment. We're not there, we're not monitoring them, so it's unattended. So if anything happens, anything technically goes wrong, we don't know it until we get the results back to download it. It records in the same setting as the patient sleeps, which means that the patient could potentially be more comfortable. We kind of get a better idea of what their natural sleep is, but it also removes a lot of the standardization that we're able to do when they come to the sleep lab. Like when a person comes to the sleep lab, we know if the TV's on, we can take that out. We know they're sleeping by themselves. We know there's no pets in the bed that's causing them to wake up. When they're at home, we have no control over that to kind of take all those factors out. First night effect, you probably all experienced it. Like the first time you're trying to sleep in an unfamiliar place, either sleeping at a friend's house, sleeping in a hotel. Same thing for a patient coming to the sleep lab. It's an unfamiliar place and we're trying to get them to sleep. So first night effect is that kind of nervousness, and you might sleep a little bit lighter, take longer to fall asleep, not feel as comfortable because you're unfamiliar with the scenario. Home sleep testing takes that out because the patient should be comfortable if they're sleeping at home. They're not coming anywhere, they're sleeping at home. The problem with home sleep studies is that they are unattended, meaning we are not there. So if something were to go wrong with the study itself, like a technical issue, the patient pulls wires off, we're not there to put them back on. So we do have a lot of technical failures with this type of testing. The patient potentially hooks themselves up. It's kind of 50-50 what the labs do. Some of them have the patient come in the evening time. They're kind of our first set of patients. We set them up, send them home. Or they might come in during the daytime and we show them how to put on the kit and send them home with it, and they put it on at night. With that opens up a whole Pandora's box of potential issues. Like, number one, did they put it on correctly? How do we know they put it on themselves? How do we know that, we're trying to test this 400-pound truck driver to make sure he can keep his job and not have any restrictions on his work, and he didn't put it on his 90-pound wife? It's happened before, and it has happened. So there's issues with that. And what do we do with every single patient when we first meet them? Verify who they are. Right person, right test, everything. By sending them home with it, we lose that. I mean, we can verify when they come into the lab, but we lose that ability that test was truly done on that person. It's a reduced minimal test. It's bare bones. It's not, you don't have EEG, you don't have EKG, you don't have any of the gold cups. It's bare bones. So the data that you're getting from it is very limited as well. Insurance reimbursement sucks. It barely covers the cost of the time to have the patient come in and set them up with the equipment, review the sleep test, and then the equipment itself is pretty expensive. Um, and because they're taking it home, again, like what happens if they drop it in the toilet? What happens if they don't bring it back? So to for the labs to like recoup the cost and finally like make enough money off of these things to even cover the cost of the equipment, it's not a money making enterprise. I know that's not what we're here for. We're not here. I mean, obviously you guys are here to because you want a career, and this is the type of program that prepares you for a career, not just a piece of paper degree that you're going to have at the end. So yeah, you're all in some regards about the money, and this affects our jobs. It has been affecting the field greatly, in that insurance companies have been dictating more and more labs go to home sleep testing, and they are limiting the patients that we can do in lab. So it is limiting the amount of jobs out there. So this is something that is currently impacting the field right now. Um, Pretty much the only reason why we should be doing home sleep studies is to determine whether or not the patient has obstructive sleep apnea, because that's really the only info it gives us. And not even central sleep apnea or like obstructive sleep apnea. That's it, because that's all the electrodes that are getting put on. It's the belts, flow sensor, and a sat probe. That's pretty much it that the home sleep test kits encompass. We still have to treat these patients the same in terms of the initial intake, initial office visit, how much screening and evaluating we're doing of the patient's history. Just the only difference is leading up to the actual sleep study, they're going home with a kit versus coming into the sleep lab. The follow-up is the same. They're still going to meet with the physician, get the results, and follow up kind of in terms of treatment plan the same. It can be used as an alternative to an in-lab sleep study, especially in patients that find it very difficult to come into the lab, either because of health issues, travel issues, whatever. But it's really only for those patients that, like with all the screeners that we do, you guys have started to be able to pick up the clues, like a very high pretest probability this patient has OSA. We can't ever give a patient a diagnosis without doing a legitimate test on them, but it's like, yeah, we know what they got. That's the patients that this works well for. Anybody else, any significant comorbidities, if we think there might be something else going on with the patient, it doesn't do them any good to do this type of test for them. Monitor I think I said the first two, but monitor the response to non-CPAP treatment. So if we have a patient that had surgery, corrective surgery to correct some of the anatomical reasons for why they might be having sleep apnea, or if they got an oral appliance. I don't know if I think the next slide I talk more about treatment options for OSA, but they can get like a mouth thing that juts their lower jaw forward, or the new implant pacemaker. These non-PAP treatments to OSA, you do want to see, like, is it actually working for them? Because we don't have the ability to kind of follow up with them and see how it's doing for them like we do with PAP. And so they might do a repeat sleep study, but instead of having them come into the sleep lab, let's just do a home sleep test. We just want to see whether or not the treatment's working. So do they have obstructive sleep apnea, yay or nay? Because that's really all the HST does. We would not do a home sleep test if the patient has a lot of comorbid issues, because it really complicates their kind of the clinical picture of what's going on, and it can make the test inaccurate because it's very limiting what we're able to see. If the patients have anything else other than OSA, it's not going to tell us anything because that's literally all it looks for is OSA. Portable monitoring, you're not going to just kind of throw out a net and see who you catch. So kind of the general screening of asymptomatic patients, that's not what it's for. To give you an example, my one side job was like in the process of potentially getting a contract with the Department of transportation down in the city. Remember they had like a couple issues for a while with like either bus drivers or train drivers that fell asleep on the job and it caused a few accidents. Kind of had a run of a few of them. So they thought about implementing a widespread, everybody gets tested, if not, and everybody, if that pops positive, mandated treatment. And it, like, they realized they were really opening a Pandora's box with that and kind of nipped it in the bud. I would have liked to do it because I would have liked to have made the money from the hours I would have gotten traveled out there to do it. But they nipped it in the bud and decided not to do that. So it's not like a general net we're going to throw out. It's only for patients that come in, they're showing symptoms of OSA, they're clinically look like they in all likelihood have OSA. The problem with these two is that you can get a lot of false negatives with this testing. It does not monitor sleep. And so when you look at the mathematical way that we calculate RDI, we take their total sleep time. If we're not recording sleep, basically it goes by their movement to estimate what their total sleep time is. And if the patient laid there awake the entire night and didn't really move, the thing assumes it was sleeping and they're not going to have OSA because it's a disorder of sleep and it gives them a false negative of it. Make sense? So in those patients, they still got to come in for in-lab sleep test. If we do a home sleep test on them, all the signs and symptoms are there that they have OSA and this says, no, you don't have it. Well, we don't trust it. You still got to come in for a sleep study. It just delays them from getting the answers and adds an extra step. You can follow this through. Portable monitoring or home sleep testing, it's not something that, you know, any run of the mill person can just implement a new company and start doing this on people. It has to be part of an accredited sleep lab. It has to be done under the direction of a physician. There's still the same kind of standards and quality control implemented with home sleep testing as there would be with in-lab sleep testing in terms of who's doing it, who's following up, how are these patients being handled. Make sense? So it's not like any run-of-the-mill Joe Schmo can just go and like train these patients and show them how to use the equipment, even though it's very simple. And there are companies set up. So just to kind of give you a background on like the home sleep test situation. Like before I even got into sleep, they had this program for home sleep testing. And it was actually like you kind of did they have these units where you could go into the patient's home with all the equipment in it, traveled in like a little suitcase. For obvious reasons, not a lot of people liked doing that. Could you imagine staying in somebody's home all night, watching them sleep from their like living room or something? No, God, no. So that failed, flopped on its face. They kind of gave up on home sleep testing for a while. And then it started gaining traction again about 5 years ago. They revamped the units, made it so it's unattended. Um, and what really happened was the insurance companies. The insurance companies dictate how we do a lot of our thing, how healthcare is run, what they'll pay for, you know, all of that. It's not necessarily putting the patient first, it's what the insurance companies, how they want it to be done. And they implemented a policy of no in-lab sleep studies. Everybody gets it done via a home sleep test. I think MVP was the first one that did it, or CDPHP. And then the way they rolled out their program was you couldn't even go to a sleep lab to get your home sleep test. You had to use their out-of-state company that just mailed you the kit with the like threat of a ginormous bill. You had to put it on whatever night it was that you got it and send it back immediately, or else they'd hit you with this like astronomical charge. So you didn't even have anybody personal to talk to teach you how to set it up, what you're doing. Like there was no personal interaction. And because it was an out-of-state company and we are a New York State, you will be licensed by New York if you choose to work in New York in this field, our hands were tied for how much we could do. A lot of the physicians band together and said, this is not putting our patients first. We need to find some middle ground. And so the insurance company backed off, stopped pushing that they use their company, and instead allowed the sleep labs to do the home sleep testing. So the patients are followed by a physician, they get that personal interaction. But we still, you know, so it kind of like found a little bit of a middle ground. And they have backed off a little bit because for obvious reasons, it's not putting the patient first all the time by forcing everybody to get a home sleep test. They have started to allow more in lab testing again. This is what happened you saw a huge drop in jobs. It really hurt the field a lot, kind of came back up a little bit. And that's kind of where we're at now, where the sleep labs, they knew and the physicians knew they kind of had to meet the insurance company halfway. They couldn't flat out right say, no, we're not going to do home sleep testing, because it is a viable test. And for some patients, it does work really well. It's a good option and it's a lot cheaper than an in lab. But it was like finding that middle ground of, we'll do home sleep testing, but you got to let us start to take more control over it. And you got to give us a little bit more leeway on who we determine who can come into the sleep lab for an in lab test. So that's kind of where we're at right now. It's evened out. It definitely hurt the job market. Whereas this area, we were like flooded with sleep labs. We had too many to support how many people live in this geographical area. So we lost, how many sleep labs closed? 4 sleep labs closed within a span of 2 years. They were pretty much all the private based ones, because reimbursement is different for a private versus a hospital based sleep lab. But it basically left it so that the sleep labs that are left now are appropriate. The number that we have is appropriate for the size, the population that we have in this area. Job market is still, I don't want to scare you guys off from this field, and that's not my intention here. The job market is still very strong anywhere outside of this immediate area, because you got to think too, the colleges here. I've been putting out graduates for how many years now to take all those jobs. So there is a high demand for all of you, but it just might not be in this immediate area. I think Patty talked to you guys too about it, right? They were all shut down initially, because it's considered an um, outpatient study, non critical. So when COVID first really, everything shut down last March, the sleep labs were shut down as well. They slowly opened back up in midsummer, mid to the end of summer. And some of them tried to do what they could through home sleep testing. The problem is that so much was unknown, that everybody was like, no, we can't do it. And so they started having to utilize home sleep testing more. The other component of it is CPAP technically aerosolizes COVID, where during the exhalation port, if the person had COVID, it aerosolizes it. So we have to, there's a lot more like things in place now where the room has to air out for a certain amount of time after you do a titration if a person's on PAP, or you have to use like not a negative pressure, but something like ventilation requirements. We have to wear an N95 gown, face shield if we're going into a room with PAP on. Um, like it honestly, it's come way down now even more. Like they keep slacking more and more on the requirements, but what ended up for the labs to even continue to exist, to reopen, they really started pushing home sleep testing even more, just to like at least get these patients, if we could get some answers for them, so they're not delayed indefinitely. But Um, you have to have somebody on call when you're running the home sleep tests, which is honestly, it's not a big deal for a sleep lab. You have night techs on all night. You give them that number, and we know if a patient, you have to answer the phone if it rings, because it's on all likelihood one of your home sleep test patients asking a question. You still need to follow up with the patients just like you would if they came in for an in lab, and do all the follow up care. Like they're not treated any different based on how they're having their sleep test done. If there's any technical failures, it really depends on the insurance. Usually they make you repeat the home sleep test. And if you have a second I forget how many technical failures you have to have before like certain insurance companies will then say, okay, then bring this patient in. Or if it comes back that the patient was negative for OSA and it was a technically adequate study, then it's okay, let's bring them in for an in lab to really see what might be happening. Um, because of the technical fail, that's one of the things I always try to make sure I explain to the patients, so they don't get, I've seen it happen just too many times where you have a technical failure and they're just like, well, it didn't work for me. I'm not doing this again. I'm done. And they kind of stop the whole process right then and there and don't even move forward on testing, treatment, anything. They get frustrated and they give up on it. And so I try to make sure that I communicate with them that there is that chance for the technical failure. You might have to repeat it. It doesn't mean anything. Just come into it a little more forewarned so that they won't get as frustrated. And the problem too is that it just keeps delaying them from getting the answers that they want. So I get the frustration. I get it. Um, so think of the definition of ARERA. We need an EEG arousal in order to meet that definition of ARERA. Because of that, we can't score ARERAs off of a home sleep test. You get it? We don't have EEG on them. We can't say the patient definitively woke up, even if you see like in the flow channel and the respiratory channels, like everything that would look like ARERA, we don't have EEG that supports that the patient truly woke up. So we cannot score ARERAs. Because of that, you're really going off of the AHI, and you guys have all been going through these reports now. The AHI is generally pretty much always lower than the RDI. So it underestimates the severity of the patient's OSA as well. Equipment has to measure O2, heart rate, so that's the oximeter, and we have to be able to look at the raw data. Like that's just kind of the technical standards, so you can manipulate the raw data and manually score it. So at a minimum, the portable monitors, they monitor the patient's airflow, their respiratory effort, their blood oxygenation, and we're using the same type of sensors that we would use in an in-lab. So RIP belts, nasal pressure transducer, and a SAT probe to monitor all of these. Based on what we have on, if the patient's having apnea, if possible, you look at the thermal sensor. If not, you look at the pressure transducer. We're using the RIP belts for effort. We're using the pulse ox for blood oxygenation. So the typical, and this is old, I left it in here so you can kind of get an idea of the pricing, but a typical reimbursement for a home sleep test is about 200 bucks. Not a lot. And when you consider that the typical HST unit itself costs about 4 to 5 grand for like one of these things, I know this because I tried to buy more for the school and when I saw the cost, I knew it was like, oh God, I got to make these last for another 10 years. Um, and you got to think like how much time goes into these patients, the cost of a tech to set them up, the cost of, all of it. And so the reimbursement sucks. There's different types, and this is all stuff you don't have to like memorize. I just threw it in there so to get you a better understanding of there are different types of home sleep tests. So the ones that are typically used now are the ones that just monitor, effort, oxygenation, and airflow. But they do have ones that can monitor a lot more, including like pretty much the full array of electrodes, or like more than just those three. You could add on EKGs or add on legs or, whatever. So there's the different types. So the reimbursement changes as well. I throw this in there and I would probably like save this for as you guys are getting ready for your boards, because I have seen board questions that ask like a type 1 sleep study was performed, type 1 being an in-lab sleep test, type 2 meaning a portable monitor, but it's the full sleep study done but outside of the lab. Type 3 is the ones that we're typically using, monitoring airflow, respiratory, um, usually heart rate, SpO2, all of that. Because we have a lot less on the patient, we're recording a lot less data, the reports are a lot more minimal. Basically, we can get an idea of what their RDI is, or really their AHI, how their oxygen did throughout the night, how long the test was run for, and kind of the technical adequacy of the test. This is really all we have on the patient. It's very limited data. Questions on home sleep testing? Okay. So some of the other types of testing, not typically done routinely anymore, but you still might come across it, or you might come across a board question. So we'll go through these a little quicker. pH testing is a pH probe that would be inserted into the patient's esophagus, and it measures the acidity, basically looking for reflux. Reflux symptoms can actually look similar to OSA. You wouldn't expect it or anticipate it, but it can. Like my sister-in-law had a lot of coughing For her, she coughed a ton, and they finally realized she had gastric reflux. Um, so just looking at some of the different symptoms, the gasping, choking at night, that's similar to what we're asking about OSA. Um, P- pH testing helps to determine if the person there's other testing available, so that's why this isn't really done too much anymore. But a lot of our patients do have gastric reflux. It's one of those things, which came chicken or the egg. If you think about the pathology of what's happening during obstructive apnea, the airway is closing up. And so the struggle to breathe against an occluded airway, you start to get that chest abdominal paradox where the chest and abdomen get out of sync with each other, and that can work the acid up more. Or the other way, flip side of it, is a person with reflux, if they're severe enough, the acid can kind of degrade the integrity of their airway and make them more prone to having OSA. So they are two interrelated. Esophageal balloons, we talked about these already when I talked about all the equipment. Those are the balloons that are inserted into the esophagus. Has to be done by a physician. We don't, but they are the most sensitive markers for upper airway resistance. Um, for just looking at what's going on respiratory wise with the patient. Very uncomfortable for the patient. So we don't, it's not done for a routine sleep study. It's more for like research purposes, but it is the most sensitive detector of what's going on for the patient respiratory wise. Nocturnal penile tumescence. Before before like Viagra and better tests came about, part of the sleep study process was actually testing for um what's the word? Impotence in men. So just like how we put these little belts around our chest and our abdomen, it picks up the strain, put little strain gauges on the penis to test for whether or not nocturnal erections were happening, to see whether or not the impotence was psychological or physical. We do not do this anymore. It's still something that might be asked. Um, what's incredibly funny about this is the person that I used to have come to do the EEG talk. She used to do this, and she's got some good stories. But thank God this was eliminated from the sleep study process by the time I started, because I don't know if I would feel the same way about sleep if I had to do this. ABGs, Patty, I'm sure, has talked about them, blood draws from the arterial to get a better idea of what's happening with the patient's dynamics of their blood. Sometimes it can be used in more the hospital-based labs for certain patient scenarios, but because of a lot of labs are off-site, not typically used for a routine sleep study. Actigraphy. I think I've talked about this too, but I'm going to touch on it again. Essentially, it's just the monitoring of the patient's activity. So your Fitbits, your smartwatches, it's the objective measure of what a sleep diary subjectively measures. So a sleep diary, we have the patient record when they're asleep, when they're awake. It's based on the patient being honest. This just goes on the patient's wrist. They wear it for a few days, a couple weeks, whatever, and it monitors their rest activity cycles. So we get a really good picture of what their sleep cycle is. Downloaded to a computer and can give you a really good, like a kind of a picture of what their sleep schedule is. Usually worn on the non-dominant arm. It can be worn on the ankle or leg if they think movement disorders are happening. The thing with these is insurance reimbursement is minimal, and these watches, they are very expensive because they do look for more than just the new versions of them, look for a lot more than just movement. They monitor a patient's temperature, heart rate, like all of the new, like technology is just getting so crazy. But this is what the reports would look like, well, at least the rest activity. So you can really see when there's no movement, assume the patient's is sleeping, and this patient has a very consistent sleep wake schedule. Just looks like their time in bed is short, 6 hours. Mainly used for patients that might have a circadian rhythm disorder suspected, which means circadian rhythm is our internal body clock. A disorder of that would just really have to come down to the timing of our sleep wake cycle, what time a person goes to bed, what time they wake up. See how patients doing in response to treatment. Sometimes it can be used for kids if it's hard to get them to come in for a sleep lab, but honestly, I've never seen it done on a kid. It's really they try to get a kid in if they're having sleep issues to see what's going on. So there's a lot more within what we do to be able to look for. We can add a lot more other tests that can complement it, and making sure that we're choosing the right test. You guys can do the review. What I wanted to talk about though is your MSLT MWT assessment. They're two separate assessments, but you're doing it on the same day, same 30 minutes. Just like next week, you have two, technically I separated them into two separate, the math and the communication. You still have 30 minutes to complete them both. It used to be they were a single assessment, but I separated them so if you maybe did really great on the math but struggled on the verbalization or vice versa, you only had to repeat the part that you struggled with. Same thing on this. I separated them. MSLT, you get 20 minutes. MWT, you get 10. The reason why there's a time disparity is because MWT is just communication. MSLT, there is a chart review component to it. Remember, I said before, we're going to keep building on the ones that we've covered already. And the other thing too is there's so many similarities between the two assessments, MSLT, MWT, like, explaining, going through the behavior guidelines, blah, blah, blah. I separated them so that you're doing it with two different, usually I'll do like a separate matrix, kind of a testing matrix difference where you might do MSLT with me and then you go into the other room and do MWT with Barb. So that you have to repeat any of the things that you already said for the last one. You got to repeat it again because new person, new room. Make sense? If you were like just to go back to back and be like, okay, I'm ready for MWT, you can get like, okay, I already said this and forget, So I'll do it that way. The first thing you got to do is you're going to get your patient's chart. You're going to look for signs and symptoms that would point towards the patient being excessively sleepy or potentially having narcolepsy. So it's a little different from the first chart review where we mainly focus more on like OSA and, looking for other things like that. You're going to look at the patient's PSG report. Oh, look at that. I'm incorporating PSG and TERP2 a little bit on this one. So again, you're going to keep building. You've got to look for the things that can invalidate moving forward with the MSLT, which would be a total sleep time of less than 6 hours, an arousal index of more than 20. If their arousal index isn't less than 20 and their total sleep time isn't more than 6, you need to call the physician to determine whether or not they want to proceed with the test. Here's the thing, even though by like standards and stuff, we have these total sleep time less than 6, 20, or arousal index greater than 20 invalidates the test, there are still a lot of instances where the physician will be like, you know what? I don't care, move forward anyway. Because they look at the bigger clinical picture of what's happening with the patient, especially if it took a lot to come down from certain medications, things like that. So if there's things like that that pop, you need to call the physician and figure out how they want to proceed. If there's special medication requirements, make sure you are verifying with the with the patient that they have followed through with whatever the instructions they were given. It's be on the order form. Make sure you're doing the appropriate test. If you're reading through the chart and it's like, man, this looks more like we should be doing an MWT, communicate that with the physician. And then you're going to go in and once you've gone through the chart, you go introduce yourself to your patient and you're going to explain the tests. Make sure that you're going to explain what you're doing and why you're looking, what we're doing it for. So most patients know if they're coming in for a sleep study that we're looking for obstructive sleep apnea. Well, with a MSLT, we want to kind of explain this is that not only is this how we run the test, but this is what we're looking for. We just want to see how tired you are, da 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 da. Make sure they know all of the behavioral guidelines that they need to engage in. So no smoking 30 minutes prior to each nap, no vigorous activity for at least 15 minutes prior to each nap, no emotionally stimulating or upsetting activities because that can really impact your ability to fall asleep, no caffeine, and no napping between naps. Explain what we're going to be putting it on them because again, we're only putting on a limited montage. And then when you're ready for them to start, okay, lie down, don't fight the urge to sleep. And then I'll give you a verbal cue and you're going to tell me when you're going to end the nap. Okay. MWT, we take out the chart review. It's just the communication with the patient. You're going to explain the test. You're going to include like why we're doing the test. You're going to do the behavioral guidelines, which are the same as MSLT, but you're also going to include, make sure they know not to do anything to keep themselves awake during the trial itself. Explain the montage. So you see why I really separated these two, to make sure that you guys, and you're going to be in a different room, different person when you do one and then the other, to make sure you've got to repeat a lot of components of things that are similar for the same. And you're going to tell the patient, fight the urge to sleep, and then we'll give you a verbal cue, and you tell us when you would end it based on the cue that we gave you. Question on the assessments? Obviously, we'll cover it more in lab. Communication-based assessments require a different kind of preparation in terms of like kind of putting together what and how you want to say it. I mean, you guys had a little bit of that so far with like the medical chart, kind of putting together how you want to explain the wires. These ones that are a lot more heavily communication-based take a lot more prep than that. Okay.